So let me share with you how to plan and manage a patient with a large ascending colon polyp. Uh, so this is a gentleman who underwent vertical band gastroplasty for morbid obesity. Although he reduced weight significantly, he has regained it back. And his work involves as a long distance truck driver. That is something important to keep in mind when you're managing these patients. He had a very long colon and very tortuous, and it required multiple loop reductions to achieve a stable position. And despite my best efforts, I was not able to bring the lesion to 6 o'clock. And in my initial assessment, the polyp looked benign, uh, has a broad base over a fold. My concerns were basically two things: whether I will be able to resect it completely and without uh, getting into problems with major bleeding, since these large polyps tend to have multiple feeding vessels. So we started with an injection using saline and indigo carmine. And as I started injecting, I was able to get a nice, good lift. And after injecting about 8-9 cc's, I decided to put 1 cc of 1 in 10,000 AP, followed by additional injection of indigo carmine. This was not an easy injection uh, because of its location at the top, and in this case, it's important to find one spot and get as much of injection as possible. And you may be wondering why I'm taking this much time. This was the time that it took for change of syringes from indigo carmine saline syringe to AP, followed by again additional injection of indigo carmine. And in total, with 2 injections, we are able to deliver 14 ml of saline with indigo carmine and 2 ml of epinephrine 1 in 10,000 dilution. I wanted to check whether I was able to get a good lift, and as I can see here, now I'm injecting on the other side to give myself an adequate lift. In these large polyps, I try to inject as much as possible to get a good lift away from the wall because I will be using a coagulation current instead of endocut Q that I routinely use for removing flat lesions. The reason to use coagulation current is because these polyps are fed by multiple feeding vessels of larger diameter that may not be coagulated using endocut Q. And when you use more coagulation current, your current is going to go deep and you may have muscular injury and risk for delayed perforation. So that's why it's very important to inject and have a very good lift. And this is another injection I gave, a total of 3 injections. We were able to get into the plane nicely. If you look at the papers from Raj Kashwani and Tanya Kaltenbach, they would say that, hey, you shouldn't be doing these polyp resections in the right upper quadrant or the right quadrant, and always better to resect it, bringing the lesion to 6 o'clock. and that makes your resection easy. But sometimes you may not find it easy to get there despite multiple loop reductions. And finally, I was able to bring the lesion to 6 o'clock. This whole procedure took about 45 minutes, but you're seeing an abbreviated version. And now I decided to use a stiff snare, a 15 millimeter snare. And initially I thought that maybe I should resect it in two pieces, the big one first and another one. But whenever you inject in two pieces, and you are likely to face bleeding. If in case you're able to get it around nicely, you should try that. And we were fortunate to get my snare loop around this big polyp so as to be able to resect it en bloc. And as you can see here, I was able to grasp the entire lesion with the snare. And at this point, I took the snare handle into my hands from my assistant uh, and decided to control the closure of my snare as I cut the polyp. One thing is important is to make sure the polyp head doesn't touch the opposite wall. If that happens, you're likely to create a counterburn. I used a force coagulation, effect 2, 25 watts, to cut that polyp. And at the last minute, I used a little bit of endocut to complete my cut. So here, I'm not yet started the cut. I'm just still moving my polyp to get a stable position without touching the opposite wall, and then apply the current to cut that polyp. This is very important to do it. You're seeing the process of cut right now, and it takes about a few seconds, not more than that. And at this point, I decided to use uh, endocut Q to complete my cut. Most important thing is you don't want to pull the snare out immediately. You want to keep the snare inside your channel and examine the base for any vessel that is going to bleed or likely to bleed. And my electrosurgery settings were already changed to soft coagulation so that if the vessel started bleeding, I could apply the soft coagulation to control the bleeding. There was a little bit of a small area at the edge, which I removed using the hot biopsy avulsion with endocut I as my setting, effect 1. Duration and interval, you can pick wherever you want. In my case, 3 and 3. As a routine, I ablate the edge with APC. My settings typically are force coagulation, 0.8 liters, and 35 watts. In this case, I decided to use a pulsed coagulation, uh, effect 2 in the pulse coagulation with the same flow settings of 0.8 liters and 35 watts. I wanted to get this job done quickly and move on. So as you can see, I'm creating a nice brown effect, slightly more brown than what you see with regular snare tip soft coagulation. And this deep brown effect is likely to destroy any cells that are at the edge. And this is what I've been using for the last 14 years. And in our own initial experience, almost 10 years back, we've observed that the large polyps could be cut with very low recurrence rate to about 3 or 4%. And this was subsequently shown to be true in randomized control studies, that you could have complete resection with a very low recurrence rate if you cut the polyps right and if you ablate the edges and make sure that the defect almost looks like an uh, ESD type of defect, complete defect. This gentleman, because of his difficulty in reaching here with my colonoscopy, I wanted to create a complete closure of this defect. And we started with uh, the closure. So I just wanted to make sure that I have a complete coverage of the edge. At the left upper edge, I thought that there was something there that was not covered. When I say something there, it is um, healthy mucosa, not any adenomatous tissue. And now we've completed the ablation of the edge, and we wanted to close the defect. So I thought that because of my struggle in getting this polyp resected, given the difficulty in reaching here, I decided to use the mantis clip for closure and wanted to close it deep so as to cut down the risk of any delayed bleeding. And as you can see here, when I'm using these large mantis clips, I try to give myself some gap so that gap, the mantis clip brings the edges together nicely, and then use either resolution clips or microtech clips to complete the closure. So here you're basically seeing the closure using the clips. Uh, One thing is, you would also notice if you have observed my procedures on YouTube, I'm working from a little bit of a distance away from the resection site. Normally, I bring that very close to my scope, not this far away, but this is the way it is given his colon anatomy. And I really had to struggle to complete this procedure. So after initial closure, I decided to apply additional clips to complete the closure. So I want to go back to the comment I made uh, in terms of his social history as a long distance truck driver. And it's also important to know when you say truck driver, do they have somebody in the cabin or not? And he drives alone for long distances. And that is important to keep in mind in terms of how you manage the patient. Because if it were to bleed, then he will be alone. So I wanted to take every possible precaution to reduce the bleeding risk to close to zero, which is not possible, but very low rates. In our own experience, we have noticed for the last 14 years by applying the clips at very close quarters, creating a complete closure, mucosa to mucosa closure, with very little distance in between the clips. We have observed that the delayed bleeding rate is pretty low. In our own experience, we reported about 3 to 4%, and that's what I observed initially when I started applying clips way before others have started doing it based on the randomized control studies. Uh, but what I have noticed is it's important to apply your clip deep, deep approximation, so that you don't see any gap between the two blades of the clip, and then the distance between the two clips is just a couple of millimeters. And uh, so something to keep in mind because any delayed bleeding in somebody who is on a long distance truck driving will get into unnecessary problems. So we completed the clip closure. As you keep watching, I'm just going through and trying to see if there is any gap in between the clips that I could approximate. And again, I'm using the Microtech clip here to complete the closure in between those gaps, because this clip has a little bit of a smaller blade, and that's pretty good to apply in between the clips if you have any space that you want to cover. One thing is you notice is this is not an easy closure. I'm doing it from a distance. I call this, when my fellow is doing it, as a pole vault type of closure. I don't like that type of closure because you may not see, but sometimes you're stuck. Technically challenging procedure, but having done a lot of these cases, you get a feel for whether your clip is closing nicely or not. And as my assistant is closing slowly, I try to push so that I get a deep approximation. And this is the final clip at the left, at the right edge. I wanted to close the defect completely. So after this, we're going to take the polyp out. If the polyp is very close to your resection site, don't try to use the net there. If you try to use a net very close to your resection site, sometimes the net may get entangled in those clips, and then in an attempt to loosen the net from those clips, you'll probably pull the clips out. So don't do that. And I'll show you what I've done here. Here, when I come back, I see my polyp is very close to the resection site, and I suck it and then try to bring it to a little more distally before I use the net. So that's what you're going to see. And as you watch that, I want to comment that in this patient, we put him on a special diet for the next 4 to 5 days. And I told him not to lift any heavy stuff, or as part of the truck driver, that's his job, and also defer driving long distances, interstate distances, for at least the next 7 days, because the risk of bleeding is highest within the first 3-4 days to up to 7 days. Although the bleeding risk is still there, but we have to draw some line so that he can continue to work, and that is something to keep in mind. Here, I see the polyp close to this one. I decided that I need to change my game plan, go and suck with the cap that at the end of the scope. It is easy to suck that polyp, bring it distally, and then use the net to remove the polyp. So that's what you're going to see here. Every small thing matters, so that you can do the procedures not only successfully but also safely. Something important. I am sucking the polyp with the cap and then bringing out a little more distally. I don't want to bring it out all the way down, because sometimes as you go through the loops, you may lose traction on the polyp, and then you'll be wasting your time trying to search for that. One thing important is I want to mention here is this procedure was done under general anesthesia with endotracheal intubation. And one of the things I struggled with when I was about to do the procedure was I thought that maybe the polyp was in a dependent position, and to move him, who's very heavy, is not an easy job. We had to bring at least 3 or 4 people to position him, and that is part of the problem that you face. We'll wait for the pathology, and based on the pathology, we'll decide what needs to be done. Thank you. So here, by bringing the polyp all the way down, you're pretty safe. You can safely use the net and bring it out. All right. Thank you so much. Bye-bye.